Hello. Hi. I think we're going to get started, if that's okay. So welcome. I'm Brenda Rosen, and I work with Common Ground, which is a supportive housing provider and developer in New York. So I'm happy to be moderating this session. It's quite a privilege. This session is about primary health care and the integration with Onsite Services in supportive housing. And I'm fortunate and lucky to know the folks up here because they partner with Common Ground at 7 of our sites. Not only do they provide primary health care services, but in all but one provide case management and social services. So it really is quite a partnership. So again, quite a privilege. So I'll start by introducing the folks on the panel, hand it off to them to do a presentation, and then I'm certain we'll have time for some questions afterwards. Immediately to my left is Dr. Van Yu. Dr. Yu earned his medical degree at the State University of New York at Stony Brook. He completed his residency at NYU Medical Center, where he was the chief resident. And prior to joining PPOH in spring of 2003, he was an attending psychiatrist and then associate director of the Bellevue Hospital Center Comprehensive Psychiatric Emergency Program. Dr. Yu is a clinical assistant professor at the State University of Downstate Medical Center and at New York University Medical Center. Over to my left is Eve Goodman. Eve is the Deputy Director of Quality Assurance and Quality Improvement for CUCS. She's been with CUCS for 9 years, serving at the Prince George as a social worker for several years, followed by working at the Skimmerhorn and other supportive residence in Brooklyn, initially as a clinical coordinator and then as assistant program director. Prior to CUCS, she received her MSW from Columbia University School of Social Work and worked in shelters and supportive housing in Seattle, Washington. And during her time at Skimmerhorn, she served as the liaison between the housing team and the primary care team and was a key participant in the complex rollout of on-site primary care. And all the way to my left is Dr. Margo Simon. She is currently the Associate Medical Director for Primary Care at Janian Medical Care. And prior to coming to Janian, Margo was the Medical Director of Next Steps at Einstein's Division of Substance Abuse. She received her BA from Wesleyan University in the Science and Society program, as well as Feminist, Gender, and Sexuality Studies with a thesis on physician activism. That was quite a mouthful. I'm totally impressed just reading that. She completed her residency trainings at Montefiore Medical Center of Albert Einstein College of Medicine in the Department of Family and Social Medicine, where she is currently on faculty, as well as the Department of Psychiatry and Behavioral Sciences. And Margo has extensive experience, including integrating primary and mental health care in underserved communities, addiction, health care for the homeless, HIV, transgender care, and reproductive care. So clearly, our panel has a depth of expertise and is here to share with us.
Okay, thanks, Brenda. So the title of this talk is Weaving Primary Health Care into On-Site Services. Janian is the name of the agency where the clinicians reside. I'll explain all the different names here. So we have basically 3 goals here. The first goal is to sort of convince you of why this is a good thing to do, to provide primary care or medical care on site at supportive housing sites. And the second goal is to sort of give you a sense of how it works. And then the third goal is to sort of give you a sense of where we think this is going moving forward, right? And before I even go any further, I was just thinking overnight that this phrase primary care has actually been, I think, throwing me off a little bit, because I realized, well, I'm a consumer of primary care. I go see my primary care doctor maybe once a year, usually only when I'm sick, and I'm a relatively healthy person. That is actually very, very different than what we end up doing, and it has largely to do with all the sort of features of our clientele that we're going to talk a lot about here today. So I think if you keep that in mind, like what are we talking about here when we speak of primary care, I think that might help orient you to what we're talking about. Somebody told me that in some talks earlier this morning, people were using the phrase advanced primary care. And I have to admit that's the first time I've ever heard of it, so I'm not really sure exactly what people are talking about, but I think that might be this, so keep that in mind as well. Okay, so here's a little bit of an outline of the talk. I'm going to talk for a few minutes about like how we got to the point where we could start doing medical care at our sites. And then Eve is going to talk a little bit about the experience of the social service teams that have been at the sites for years, integrating this into their work and how, sort of the challenges of that and some of the benefits of that. And then Margo is going to talk about the process of actually doing this kind of work in supportive housing sites, and then also talk about some of the things we see in our future, the good and the bad, right? Okay, so this is sort of starting to give you a sense of like, well, why are we doing this? Like, what's the point? Why did we cook this up? So the box on the left, I'll just read them first. People living with serious mental illness also suffer from comorbid medical illness. So I'm hoping sort of most of the people in the room get this. There's reams of literature showing the burden of both mental illness and medical illness, especially among our population, which is homeless and formerly homeless people. And then on the right it says, people living with serious mental illness face many obstacles to utilizing traditional health care. So one of the things that was realized, as far back as the 80s, probably even before that, but certainly has shaped the way the system in New York City is anyway for serving homeless people since the 1980s, is this issue of homeless people facing many obstacles to accessing the medical care system, both on the behavioral health side and the physical health side, that's in existence, even in existence specifically to serve homeless people, right? So for example, a study I like to quote a lot, and I always forget the exact citation, is that in Los Angeles, this is back in, I think, the early 90s, homeless people who were seriously mentally ill in Los Angeles at the time, only 1 in 5 of those people was actually accessing any psychiatric care in the community. So that means a significant number of seriously mentally ill homeless people are out there not accessing psychiatric services. So that kind of realization in New York City anyway, and I think in a lot of other places in the country, led to efforts to bring care to where homeless people are. So shelters, drop-in centers, outreach things like that. So Janian and CUCS to a large extent also exists because of that realization. And we'll get into the history of both agencies on the next slide. So here is one of the results of the 2 top boxes. And this is sort of this famous statistics that's been bouncing around the world for the last couple of years. Americans living with serious mental illness have a life expectancy that's as much as 25 years less than Americans who are not seriously mentally ill, okay? And notice that seriously mentally ill Americans, that's not even adding in homelessness. That's just seriously mentally ill people, right? So if you add homelessness into that, I don't know that anyone's ever done exactly that study, but I'm sure the life expectancy would be even less than that. So that's sort of the main driver here, is this realization that something's not working for these people that leads to this kind of burden of mortality and morbidity. Okay, so some history about us. So I had just said to you at the previous slide that starting certainly by the 80s, right, there was this realization that a lot of single adult homeless people, certainly in urban areas in this country, had a high burden of serious mental illness. And then, we could talk all day about how deinstitutionalization really contributed to that. And that combined with a lot of these people weren't accessing the psychiatric the care system that's in place to serve them, right? So because of that, there were resources put in place, like the Project for Psychiatric Outreach to the Homeless, which started in 1986, to bring psychiatric services to homeless people wherever they are, right? Shelters, drop-in centers, homeless outreach teams, and supportive housing. And around the same time, I believe the year, there's a bunch of CUCS people in the room, so forgive me if I get this wrong, I believe it was 1983 or 84. The Center of CUCS was formed. At the time it was Columbia University Community Services, and then it later became the Center for Urban Community Services, which is a big social service agency providing all kinds of social services to homeless and formerly homeless people, including operating services in a lot of supportive housing sites. And then in 2006, the two agencies sort of like banged into each other. I won't go into the whole story, but basically the Project for Psychiatric Outreach to the Homeless became a program of CUCS, okay? That provided CUCS with a bunch of psychiatrists that it really needed for its programs, and provided PPOH like an infrastructure that they didn't have before. I always like to say that the day the merger happened was like the best day of my career. I went from being a program director to being a medical director, which is a much better job, by the way. So between 2006 and about 2011, I'm merrily going along, like hiring psychiatrists and placing psychiatrists out in the community, and I'm a psychiatrist and I know how to do that, so it was all very happy, right? And we had this way of, and then, unfortunately, I think one of the things we have to talk a lot about is sort of how the business of it works. So the Project for Psychiatric Outreach to the Homeless, up until today, is funded by government money, some philanthropic money, the most consistent source of that being the Robin Hood Foundation, and like fees that we charge programs. So if I send a psychiatrist to a shelter, that agency pays PPOH for the time of that psychiatrist, a rate that ends up being much lower than the market rate because it's like supported by the government funding and the philanthropic funding. Okay, so notice no third-party billing there, right? And I'll talk about the consequence of that in the next slide. Okay, then in about 2010, a couple of things start happening. The first thing is New York State corporate practice law changes. Okay, so why is that a problem? PPOH isn't a licensed entity. We don't have a license, Article 31 or 28 license. However, part of our funding comes from the New York City Department of Health and Mental Hygiene. So our lawyers told us, well, then you're fine, because the local health department's like giving you money to do this, right? Then the corporate practice law changed in New York, and then our lawyer calls and says, well, now you're in this like gray area of the law, right? So basically he's telling us we're practicing medicine illegally. So we have this choice. We can either get a Article 31 or 28 license, which we didn't want to do. Just for one thing, adhering to the regulations of one of those licenses will make it very difficult for us to do what we do, which is deliver, like, doing healthcare on a park bench is like difficult to do when you're like having to adhere to regulations, certain kinds of regulations, for example. So what we would do instead is we became a professional corporation. So PPOH was pulled out of CUCS and it became a separate legal entity that's a professional corporation. So your primary care physician, if he's working like in a group practice, that's probably a professional corporation, like that kind of thing. So that's an entity that can legally practice medicine. Okay, so what is the consequence of this? So the top part, the PPOH part, I already gave you a sense of, right? So it was completely funded by these sources, like the government and the philanthropic funding and the fees we were charging. There was no third-party billing. So everything's paid for on July 1st, right? So the psychiatrist, it created an environment where the psychiatrists aren't having to like worry about, oh, I got to see 20 people in a day to make my salary, like that sort of thing. It gave the psychiatrist the ability to figure out, well, what is the best way to serve this population? What is the best way to be a psychiatrist for a homeless person in a shelter or formerly a homeless person in a supportive housing site? Okay, and I'll sort of give you the result of that in the next slide. And then now that Janian Medical Care is formed. I forgot to tell you that. So the entity that we pull out of CUCS to become a professional corporation, we call Janian Medical Care. I won't go into the whole sordid history of where that name comes from, but Janian comes from the god Janus, I believe the Roman god of doors and fences and gates, the god of transitions. So we thought that was fitting, right? So that's where the word Janian comes from. So what happens with Janian, one of the consequences of that is, remember, we were, PPOH was funded by the City Department of Mental Hygiene back when the Department of Mental Hygiene was a separate department to do psychiatry, right? So we could only do psychiatry. When we became a professional corporation that can legally practice medicine, we can practice any kind of medicine. So that was like the first thing, like, oh, right, we can do all this other stuff now that we weren't able to do before. That's the first thing. The second thing is, for years, we've been watching a cohort of our clients. So there's a cohort of clients who are homeless or formerly homeless, who, in addition to not making use of the psychiatric care that's out in the community, were actually also facing obstacles, similar obstacles to accessing the medical care in the community. So we're providing good psychiatric care, but we're watching people not really be able to hook into good medical care, right? So we saw that. That's the second thing. We saw the need, and then we see this. There's this ability now to do it, and then Obamacare happens, right? So now, because of Obamacare, a lot of philanthropy becomes really interested in funding, like, medical care for homeless people, integrated behavioral health care, and primary health care. So we went out and got some of this philanthropic funding, New York Community Trust, the Oak Foundation, for example, to get some seed money to get a primary care operation off the ground. Yes? And so that's the good news. The bad news is, which Margo will talk more about later, is that seed money is going to run out like any minute now, right? So we have to figure out how this all fits into the new healthcare environment so we can keep the thing going. Okay, here's my last slide. I'm going to just put the whole thing up there. Remember I said before that one of the great things that I walked in on at PPOH was that the whole thing's funded like starting on the first day of the year. We're not billing things as we go. So like I know how much resources I have from the first day of the year, right? So then I can place a psychiatrist at a place, and that psychiatrist can decide, okay, what's the best way to do this? And I'm sure it's not a surprise to, I'm hoping, most of the people in the room. What you realize is the way to do this is you do this person-centered care, right? And this slide just talks a little bit about that. I'm going to actually hand it off to these guys, and they'll talk more about that. But basically, what that means for us, or what we like, the way we like to talk about it, is that what we realize very quickly is that one of the big obstacle for people not accessing care in the community is there are lots of obstacles, but one of the big ones that we thought that we could really address very well is people not being able to get into good relationships with caregivers, right? And so one of the advantages we had of being on site was that we were able to really develop relationships with people, and we realized, well, that's actually most of the work, right? Prescribing the Risperdal is easy, right? But there's all this groundwork you do before that, right? And so we like to say the relationship is the treatment, because that's where all the care comes. The care comes out of the relationship, and it's hard to do that when you're seeing 25 people in a day. It's hard to do that in 15-minute slots every 6 weeks or something like that, right? So that's why I say that's what's at stake here in figuring out how to keep medical care going at these places. So with that, I'm going to hand it off to Eve Goodman, who's going to talk about the experience of the social service staff with this.
Thanks, Van. So while Van and his team were doing all of this, I was a social worker at CUCS at a supportive housing program, along with a lot of other social workers. And then I was a supervisor, supervising social workers and case managers, and working with clients who were getting really sick and who were often getting so sick that they were dying. And we were struggling to get the medical care in the community. But this is what it was like. This is my little slide here, showing what we were doing, what we were comfortable with as social workers, as social service providers. We knew about housing. We knew about homelessness, substance use, entitlements, mental health. If you're a social worker, you take many classes in mental health topics. You do not take a class that tells you what a pulmonary embolism is. You do not necessarily know anything about liver function tests or about different types of hepatitis. You might, if you're working in a hospital, or if you happen to have a client going through those problems, but you don't necessarily. So when we went to try to help someone have medical care, we were in the dark cloud of mystery along with them in most cases, trying to access medical care, but having no real idea how to do it. And the characteristics of sort of as an outsider in the medical universe, trying to get medical care, it was very difficult. Perhaps people in this room have had that same experience. I suspect many of you have. Outside medical providers often don't know anything at all about mental health and substance use factors, right? They might have taken a class on it, they might have had other patients with those situations, but they're not going to necessarily think of those things with the same breadth that they think of medical topics. On the other side of it, housing providers, I know that I wasn't very knowledgeable about physical health topics. And so the relationship tends to be adversarial and confrontational. You're trying to fight for things, to get things for the person you're working with. You are doing a lot of time-consuming and repetitive tasks. Maybe you're scheduling the same appointment 12 times and the person still doesn't go, and you can't figure out why not. And then one day you go with them to the appointment, which maybe is an hour away because that's what their insurance would cover or where they felt comfortable. And you discover that they're waiting for hours in a clinic waiting room, and that the receptionist is looking at them funny because they smell bad, and that they forget to actually tell the doctor what's going on with them, and that they're scared, the same way that you or I might be in going to a new doctor for the first time when you don't really want to go to a doctor, but with added burdens and added difficulties. Our clients often were overwhelmed and frightened by having to make choices about their medical care, and at the same time desperately wanted to be in control of their choices, and the doctor didn't necessarily want to have them make a choice because as soon as they saw schizophrenia on the medical history, they thought that person wasn't able to make decisions, which is not true. So medical care then would often miss the point of what the person was really walking in the door with. Perhaps the person seeking care was concerned about stomach pain and did not really want to talk to anyone about smoking cessation. Imagine that, right? So that happens all the time. So when we started having primary care, it was very sudden. One day I woke up and there was primary care at the Skirmahorn, where I was the assistant program director at the time. It was exciting, but we really didn't know what it was going to look like. And this is sort of what it would look like, what it looks like now, is this. Oops, yes. So once a week in a supportive housing program where you have a congregate facility, there's a lot of different tenants receiving on-site social services. There's a primary care provider with a medical assistant working on-site in the offices together with the other existing staff who are there. Workers and managers collaborate with the primary care team to assist tenants to come to appointments. At the appointments, they have questions answered about their medical health. They get lab work done right there. They receive vaccines, physical exams. They're prescribed medications if medications are needed, right? And then after the appointment, the housing worker's manager will assist tenants in following up, making changes in their lives to improve their health, taking medications, receiving imaging, diagnostic tests outside, maybe going to a specialist outside. And those are the things that are done on site. And this did not happen in a poof kind of fashion. It was actually very time-consuming to make it work. And it was, while not expensive in the broad scheme of possible medical expenses, setting up a lab, getting phlebotomy chair cabinetry is something that is not as easy as just sitting and talking with someone in the way that you might as a social worker providing mental health counseling and case management services. So some of the difficulties, these are some things in kind of smaller print than I had thought, so I'll read those. These are some things that I heard from people I supervised and that I thought myself over the first challenging, difficult period of integration. For example, What does this note even mean? I need to know if he can still get lab work done even after he ate breakfast, not all these details and weird doctor abbreviations. What is this stuff supposed to mean anyway? Right? Nothing by mouth, NPO. So concrete knowledge acquisition is a barrier. When you first start integrating primary care into a supportive housing program, suddenly staff are part of a medical team without any medical training. We're not doctors, we're not providing medical services, but you still have to kind of know what they're talking about in order to be an advocate and a partner with your client. The next thing that happened was, how am I supposed to explain to Jerome that she won't give him the same meds his old doctor did? I told him the care here would be better. Would it really kill him to get the Benadryl? He says he needs it to help, to sleep, and I believe him. So the people we're targeting for primary medical care services are by and large people who did not have primary care providers in the community. However, it doesn't mean that they never had medical care before. They might have once had a doctor many years ago who gave them all the oxycodone they wanted, they remember, or who was willing to refill and refill and refill without ever seeing them for an appointment. Sometimes care that to me seems less good, to the client maybe seemed better. Perhaps because of their trauma history, they maybe didn't want someone giving them a physical exam and having their hands all over them. Perhaps they didn't want a medical provider who was going to ask questions about their substance use. So people being happier with substandard care was a difficulty that we hadn't anticipated. Something else we heard. As soon as she started seeing the provider here, all of a sudden there's all this stuff she has to do. If Liza were someone who went to doctor appointments and checked her blood sugar and took meds, she wouldn't need care here in the first place. This is true, right? As soon as someone sees a doctor, they're sick because the doctor finds all this stuff. And then you have to deal with the stuff, and it's work. Obviously, we can sit here and say it's better to know and follow up and get care, but if you're the case manager trying to balance all of a sudden 3,000 new things you now have to do because your client went and saw Margo for an appointment, it can feel very burdensome. And then someone might say, if I'm going to be a partner with the provider, like you keep saying, why isn't she listening to me? There's no way Jim's going to take all those pills. It doesn't matter what his blood pressure is. After all, his pressure's been high for years, and he's been fine so far. We may know the psychosocial factors for our clients as case managers and as social workers and what they want, and not necessarily know how to collaborate and partner with the primary care providers. So, given that all those things were happening, we dealt with them and are dealing with them. This is a present tense slide. Through a variety of approaches, with managers acknowledging the difficulty and giving permission to workers to not suddenly know all of medicine and to be experts. With medical providers providing both formal and informal sort of instruction, education to the non-medical staff about the medical topics. That might mean a case manager calling up the provider and saying, hey, can you translate these labs for me? Or it might mean a lunchroom conversation about what the heck is blood pressure anyway. Or it might be a case conference about seizure disorder that then leads to a better understanding of when you do and don't need to call 911 for someone having a seizure. You usually do. So the workers, on the flip side of this, helping medical providers understand the psychosocial aspects of the care. It turns out that in medical school, they don't teach you about food stamps. Which seems very weird, but apparently not, right? I mean, so there's a lot of things that we as the experts, together with the clients who are the true experts, were able to help inform the medical providers about that they hadn't realized or wouldn't realize. And then also a certain amount of mutual benefit. It's much easier to help someone get a home health aide if the worker can ask the provider to fill out the paperwork at 10:45 in the morning, and then it gets filled out by 11:15 and faxed over, and then if there's a problem with the paperwork, you correct it in the next 10 minutes. Same thing with helping someone get a TB test to go to detox, or any one of a number of other tasks. And then highlighting success stories, in any kind of new initiative that you'll integrate as a manager in any program, that you have to sort of show what works and pay attention to what's working and do some positive reinforcement along the way about what's difficult. And we tried to highlight success stories that showed the progression of knowledge for all concerned and the progression of competence, to recognize overlapping and different expertise, that our expert knowledge can be mutually beneficial and sort of bring out and will elicit expertise from the partner. So this is all a work in progress, but this is my last slide about why we're doing it. And we're doing it, at the risk of being a little cheesy, because of Estella, which is not her real name. She moved into supportive housing in 2013. She has a lot of serious health conditions, diabetes, hypertension. She's got HIV/AIDS. She has seizure disorder. Psychiatrically, there's bipolar disorder. She has a trauma history, and she has opiate dependence, and she's actively using. She's terrified of dying alone, in a nursing home very specifically. And what she said on the first day she moved in was that if we ever sent her to a nursing home, she would kill herself. In the first year that she was living with us, she had shingles, she had pneumonia twice, she broke her collarbone after a seizure, she went to 28-day drug rehabs twice but left early each time, as well as many, many, many other smaller crises that were too many to fit on the slide. So what we did, because we weren't going to ignore all of these issues and we were giving her the best care that we knew how, was we talked about everything except her health. We talked about her substance use. We talked about her social relationships. We talked about her bereavement. We talked about her childhood trauma. We talked about who's important for her in her life. We talked about her bed bugs, and she had bed bugs. We talked about everything except health. And then we did talk about health because we had to, because she was so sick. So we said, you should really take your HIV meds. And then we thought, oh geez, maybe that's a mistake. Isn't it supposed to be worse if people only take HIV meds sometimes? It is, right? So maybe we shouldn't say anything about the HIV meds. Oh, but that can't be right either, right? She wanted to go to rehab. Wonderful. Off she went to rehab. She left after 3 days because they wouldn't let her put sugar in her oatmeal because her blood sugars were over 300. She had a doctor she'd seen in the Bronx who she liked. That's the only doctor she was willing to see. We went with her, the social worker, to the Bronx on the subway. It took forever. And then she left because she didn't want to have to wait. This happened multiple times. She would refuse referrals to more near places. We would find places and they would refuse her. We wanted her to get medical care at her methadone program, but they said she was too medically complicated. You get the idea, right? I see some looks of familiarity. I feel like there are people in this room who have had similar experiences. So then we had primary care. And this is what happened. The primary care provider went with us to her apartment with her permission and talked to her in the apartment as well as in the office about her health. Taught her how to use a blood sugar monitor and explained why she might want to use one. Discovered that she hadn't had test strips for years. Got her test strips. Reduced the number of blood pressure medications to just one because it would be easier for her to take. Got lab work and explained it to her. Went to her apartment again when her sugars were really high and realized that she had her 2 different kinds of insulin mixed up and didn't know which was which, and reduced it to only one type of insulin. Provided refills when she lost her meds and advocated with the insurance company to pay for it. Set up transport for her to get to an infectious disease specialist, and then transport again when she didn't want to go to that one, and then transport again. Began a conversation with her about sexual safety that continued when she was sexually assaulted. Talked to her about GYN care and how she could receive trauma-sensitive GYN care and trauma-informed care in general, and that GYN care could be something that could be possible for her despite her history of trauma. And this one was just like something that seemed so easy, but helped her switch to insulin pens instead of to needles, because needles were a trigger for her with her history of injection drug use, which had never occurred to us at all was even something that was possible to do for her. So this sounds, to me, it's a dream come true in a lot of ways. And it isn't easy and it wasn't easy. But it's working really well for Estella and for people like her. And Margo is going to talk about how she did it.
Good afternoon. Thank you, Eve, for that introduction. And thank you all. So why don't we just step back to set the stage a little bit more to help people to become a little bit more familiar with what we mean by primary care. As Van already mentioned, it can mean different things in different contexts. And so here's just an example of some of the things that we mean when we use the words primary care. It includes health promotion, disease prevention and early detection, health maintenance, counseling, patient education and empowerment, diagnosis, treatment, management, and follow-up of acute and chronic illness, engagement in the therapeutic alliance and process, access to care for a wide array of conditions, and a hub from which patients, or in this case tenants, are guided through the healthcare system, as well as founded in participatory decision-making by tenants. Well, what does this look like in supportive housing? So, our tenants have significant obstacles to high-quality integrated care, as Van has already described, and there's a breadth of literature to document, unfortunately. Our tenants are at risk for serious health conditions and grave outcomes. There's a high comorbidity of mental illness, of addiction, of psychosocial struggles, of chronic and acute illnesses. And as a result of these things, there are excessive hospitalizations and emergency visits, many of which, over time, are actually largely preventable. So let's look at who is living in CUCS housing and what their hospitalizations are like. So in 2014, this is basically a summation of the number of hospital days spent by the highest utilizers who are tenants in our organization. And so the highest utilizer spent 336 days out of, exactly, 365 days, unless it's a leap year, in 2014 in the hospital or in a hospitalized setting. And you can see how it goes down, and these just happen to be our top 25 highest utilizers. So not only have we talked about how the poorly managed health leads to preventable hospitalizations and ER visits and illness, but decreased quality of life. And this is tremendous. The amount of suffering that people that we work with have already experienced is now confounded by the suffering of their mental health issues. People who've spent decades living on the street, especially if they're intoxicated on various substances, don't necessarily experience the suffering of their medical problems because of where they're at in life. And then when they come into housing, as many of the other things in their life start to get back on track, often they are aware of all of these medical problems that they didn't know they had or didn't pay attention to, and a lot of illnesses start to show, and you really see dramatic decreased quality of life as well. Usual community care models have failed many of our tenants. There's no other way to look at it. There's no other way to say it. And that is one of the main contributing factors to why so many of the people that we work with have such terrible health outcomes in the long run and have such devastatingly lower life expectancy rates. And so we have a Janian developed resource-intensive on-site primary care services. I think it's important, this final bullet, to recognize that we have a complex targeting process, a procedure, to target the most complex clients who have been unsuccessful engaging in usual community-based care. And the reason I point this out is because one of the challenges that we found when we started doing this is that most of the tenants, and frankly I think the social work staff as well, the social service staff as well, is they're used to what I call the school nurse model. And basically that is having a nurse who's available on site to provide first aid, to provide acute care when something comes up, to provide a refill for an asthma medication because it's raining and they can't make it to their primary care provider. And so many tenants and staff were used to this model. And when we started providing primary care and I came to the agency, we realized that that was not the need that we were trying to address. There's a broader need in terms of primary care to really address some of the fundamental things that are ending people in the situation that we're talking about. And so from the triple aim to the triple I, and this is we're toying around with some different names to describe what we're doing. Triple I to the 3, I cubed. So please feel free to give us some feedback about that. So what is the triple I? Janian person-centered collaborative care is intensive, individualized, integrated care. And the benefits are exponential rather than just additive or summative, hence the I to the cubed. Here are some features, some key features of I to the 3rd. Collaboration and coordination. And so Eve talked a little bit about what that looks like. On one level, it's about staff coordination and collaboration, which is bidirectional, as Eve described, and bilateral. We have 30 minutes at the beginning of each primary care day to sign in with the medical liaison, and then another 30 minutes at the end of the day to sign in with our medical liaison to make sure that when a tenant comes to see one of our providers, not only do they know what the tenant tells us when we're sitting together, and often the worker will accompany the tenant to this meeting, but also what has been going on that the tenant might not be telling us. And actually on our referral form, we have 2 initial questions. One is, what does the tenant say is the reason for the appointment? And what does the worker think is the reason for the appointment? In addition, we have people who are on site all the time. So even though we only have primary care providers there 1 to 1.5 days a week, there's medical work that's happening all the time. Medical treatment planning realization is happening day in and day out. The way the social service staff is engaging with their tenants surrounding obtaining primary care. And so we talked about the difference between reminders of appointments, for example, and engaging in conversations. How did things go with Margo when you saw her last week? When is your next appointment? What are the medications that you're taking? How are you doing? Oh, you're not feeling like you want to go back? Why don't we talk about what's going on? And really engaging tenants in a meaningful, substantive conversation to help people to get engaged, to develop the therapeutic alliance. And then, of course, there's actually the collaboration with the tenants themselves. We really see this as a partnership. We know that we can suggest all of the most optimal medical care known to humanity. But if the tenant isn't going to follow any of it or only parts of it, then that guidance is essentially useless. And so it's really about having an ongoing conversation, understand where the tenant is coming from, where they're at, meeting them there. Not losing sight of the longer term goals, but not sacrificing the long-term goals and the long-term relationship and the improved outcomes in the name of short-term CYA or short-term interventions. The care is long-term, person-centered medical treatment planning, in part as I just described. I'll give you an example of this. So somebody has high blood sugar in a more traditional setting. Let's say their blood sugar is 600, which is, depending on the type of diabetes you have and the circumstances, dangerously high. However, I'm sure you've all seen this happen before. You send the person to the emergency room, there's some sort of conflict because 911 shows up and the person doesn't want to go and EMS is trying to tell them to go and you're trying to tell them to go and there's some sort of conflict. They go to the emergency room, everyone's thrilled the person's going to be getting medical care. They get 10 or 15 or 20 units of insulin. They maybe get a few paper prescriptions and they're sent home again just to a few hours later, depending on the type of insulin they were given, or the next day, again, have a blood sugar of 600. And this will happen every single day until something changes. So and using this as an example, one of the things that we would do is our primary care provider, maybe that very first time, or when it felt like it was going to be okay for the therapeutic alliance, if the person's asymptomatic, if the person doesn't have any signs on exam that they're actually at a dangerous level, instead of just repeating the cycle, we might work with the tenant to make a plan. All right, if we're not going to go to the emergency room today, we're not going to call 911 today, what can we do so that when I see you next week, or in 2 weeks, or in 4 weeks, it's not going to be so high. And we have to tolerate what can be quite uncomfortable, which is sitting on the knowledge that a person's blood sugar is 600 for a few days or even weeks. But with the perspective that that person's been living with a blood sugar of 600 for the last 2 weeks or 2 months or 2 years. And really, again, thinking about the long-term goal rather than, a blood sugar of 600, we have to get the person to the emergency room immediately. Certainly there are times in which you have to do that, but by knowing the individual, by having the intensive on-site relationship with the staff and with the individual, we're able to monitor things very carefully and avoid sending people to the emergency room when unnecessary, and to avoid having conflicts that can challenge the therapeutic alliance, not only with the provider, but also with the staff. Therapeutic alliance, as Van said, it's the mantra. the relationship is the treatment. That is fundamentally what is at the core of what we're doing here, and on some level we think why it works. Time is critical. Van already mentioned a 15-minute visit doesn't get you this. It doesn't. An hour of our day is dedicated to case conferencing surrounding the tenants that we see that day. No time for case conferencing doesn't get you this. Patience with the tenants, and more time. And more time and more time, and quite frankly, I wanted to keep going time and time and time and time, but I think that you get the point. It's quite intensive care that we're talking about. And then finally, integration. So why don't we talk for a few minutes about what is integration? What does that look like? So historically, there are a number of different models for how to integrate care, integrate behavioral health care into medical care, integrate medical into behavioral health, co-location of services, consultation models, it goes on and on. Initially, we talked about layering on primary care to the existing psychiatric services, and we think that a lot of those more layering models rather than the weaving together integration models fall short. And so specifically, at Janian Medical Care, or PPOH of CUCS, in the buildings that are managed by Common Ground, we have a number of levels of integration. So we have the primary care integrated into the existing behavioral and mental health care services, integrated into social services, which are extensive but include sociooccupational rehabilitation, such as the career network, getting people back to work, getting people volunteering, getting people involved in their community, finance management support, rep payee, care collaboration, which is a lot of the glue of the work that's done by the staff to make what we do possible. Assisted self-administration of medications, where we are able to know if people are or are not taking their medication and address with them why they are or why not, and how can we, manage that. And then, of course, housing. So this is already 4 different levels of integration, and they really do have a synergistic, exponential relationship. Rebuilding lives together, that's is it hashtag? Ron was just here before. For CUCS. So a couple of anecdotes that I think are quite powerful, in addition to the one that Eve already shared, which I think demonstrates some other elements. So FR is a gentleman in his late 50s who has been living at one of our sites for a couple years. He had been street homeless for decades. And when he got there, he came with a diagnosis of schizophrenia, and he was extremely withdrawn. Aside from responding to internal stimuli, he was barely accessing services. He was not going out in public, and his psychosis involved beliefs about contagion and infection, and he had a bleach concoction that he would make in his apartment, and he would clean his legs with the bleach concoction. Now, bleach may be appropriate for the tabletop in a medical exam room, but if you put it on your skin, you will destroy your skin. He already had severe venous vein illness in his legs that was causing swelling. His skin was breaking down. He couldn't walk. He was getting infected on a regular basis, and the social service staff, understandably, was quite beside themselves and didn't know what to do. He refused to go to care in the community, and he would just bleach and scrub his legs to the point of rawness, and of course that was making everything worse, even though in his delusional system that's what he needed to do. And so he was willing to allow our primary care provider, once we had services at the site, visit him in his room. And so she went to the room with the social service worker and with the medical assistant and saw these vats. His whole bathtub was blue with this bleach concoction. And they were able to see the conditions in which he was living, which on top of the destroyed skin, with the hygienic situation in the apartment, was very difficult. And so he let her in the door. A few weeks later, he let her in the door. For months and months, he wouldn't come down. And there was very little typical practice of medicine, if you will, that was happening when she would go in to that room. She would make sure there was not something acutely happening from an infection perspective that would require antibiotics or an emergency room visit. She was working to build his trust. Countless hours of working to build his trust. And while this was happening, as we were in supervision, we talked about the importance of the role of a mental health provider. And luckily, Dr. Van Yu was the on-site psychiatrist for this fortunate site. And so we said, we just have to get Van in the door, the same way that he was letting the PCP in the door. And so she became a foray. And I believe the first few times that you met with him, it was behind a closed door, and then after a few visits, he would open the door, and I think eventually he let you into the apartment. Again, never coming down to get medical care, just we were trying to keep him at least safe. And then something happened, and everything got swollen in his body, and he was able to think outside of his psychosis, and he needed a prompt medical care. He brought himself, I think he called 911 and ended up in the emergency room. It turned out he had congestive heart failure. While he was hospitalized, it was clear that he was actively psychotic. He left the hospital after a lengthy stay on an injectable antipsychotic medication, returned to his housing, briefly continued to see the primary care provider on site, continued to see Van, who was now actually able to prescribe some medication, and is walking around in public spaces. He's talking to people. He's leaving his room. He's taking multiple medications that are keeping him alive because his heart function is so dramatically declined at this point. And ready for this? He's graduated from our primary care program and is seeing a provider in the community through the HHC system.
If you told me that was going to happen 2 years ago, I would have bet real money that it would. Like, this guy was one of the sicker people I'd ever worked with.
And he's still one of the sicker people that we work with. He's still psychotic, but his level of daily functioning is dramatically improved, notwithstanding his ongoing medical and psychiatric symptomatology.
Good job, guys.
It was a team effort, which I think is really critical here. It's really a team effort, which includes the tenant in this. And I'll try to tell this one in the name of time a little bit more briefly. So SL is a tenant at another one of our sites. And he has a history of hepatitis C, of intravenous drug use, although he's been in recovery for about 20 years, diabetes, although we don't know how long, he's been in some denial about it for a while, hypertension, hyperlipidemia, and he came to us, and schizophrenia, excuse me, and he came to us for medical care. He had a very hard time at the beginning understanding the difference between blood pressure and blood sugar. And so even though we were trying to teach him about how we want his blood sugar to be under 180 after he'd eaten, he thought that any blood pressure under 180 was good. But of course, that's too high for blood pressure. And so it took a very long time to get that to happen. In terms of his diabetes, he had a delusion that there was a silver creature living inside, like a metal silver creature living inside of his body that was responsible for the fate of the world, and that creature inside was fed by soda. And so he had to drink soda. There were a number of dietary interventions, unsuccessful, until we learned through getting to know him, through time and patience and a high tolerance for acute risk, that he was feeding the salvation of the world, or at least that's how he experienced it. And so, all right, what can we do to keep the world alive while keeping you alive? And so he initially agreed to come and see our medical assistant once a week to have his blood sugar checked. He even agreed to check his own sugar once a week in front of his worker, just to have some structure. And over time, his blood sugar, his diabetes, his high blood pressure, his hyperlipidemia are under control. I saw him one day when I was visiting the site, and I asked him how he was doing, and he said, "I'm not doing well." And I said, "What do you mean?" Because it sounded to me like he was doing very well. And he was telling us that the needle sticks for his checking his sugar were starting to trigger his distant addiction. And this is something that we wouldn't have known about because he wasn't talking about his addiction. His addiction was 20 years ago last active. And so it was through talking to him about his medical care that we were able to learn that he was on the brink of relapse. And therefore we were able to get the team together and put together a troupe of people to work with him to prevent relapse. So we're looking at some numbers now too. What we're doing is an outcome study with an initial cohort of 154 people. These are people who had been living in the sites for at least 365 days before primary care got there, and then started receiving primary care and was receiving primary care services for at least 365 days after it was begun. And we found that the total number of hospital days decreased from 1 year to the next by 751. That's nearly 40% decrease in 1 year. We found the total number of hospital visits decreased by 55, which is, again, a quarter of a decrease in 1 year. Total ER visits decreased by 27, or nearly a third. And here's the data with the absolute numbers. I should say that I am predicting that it's going to be even more profound when we look at the next year, because up front, when we're finding out how sick people are and we're starting to treat them, people spend a little bit more time in the hospital in the emergency room once they're engaged in care before the primary care works to stabilize them. So I think we're actually going to see some more dramatic results going forward. And here's just a graphic demonstration. Look at that line, the slope of that line. It's like a downhill skiing or something. And then we see the same thing. Sorry, I'm not a skier. I shouldn't have tried to make a reference that I'm not familiar with. Again, impressive, I think, visually to see. What's that? Okay, good. But here we are. The reality is that we have extreme sustainability challenges. Historically, the program was funded by grants. Those are essentially going to be drying up. We're embarking on MCOs, but MCOs manage care organizations. But as everybody knows, the reimbursement rates for MCOs will get you 25 to 30 patient visits a day to be sustainable. And then there's alphabet soup and a lot of other things that are going on. Right now, Janian and CUCS are in the process of working towards an IPA, which is an Independent Providers Association. It's sort of like a union of providers, so we can have some negotiating power with with the MCOs, a contract similar to the work that we're doing with in PPOH, as well as some DISRIP applications. So in summary, lessons learned, this care is needed, this work is needed. I to the 3 or I cubed, it works. It works well. It's resource intensive as an investment, but undoubtedly there is extensive savings and it's resource conserving returns. Thank you very much.
Thanks to our great panel. I had a bunch of thoughts as this was going on, including, so I've been with Common Ground for a long time, been working with CCS forever, feel like I know so much, and then go through this and learn just a ton more and feel like, well, I didn't know that much to begin with. But one of the things that really struck me just as a quick comment was how folks up here are talking about the relationship really being the treatment. And when thinking about kind of the synergies between all the things that happen in supportive housing, starting from the street outreach going into permanent housing. We always say that when we're working with folks that are chronically homeless out on the streets with decades of homelessness behind them, and mental health issues and medical issues, that one of the biggest successes is to form that relationship with a person. Because once you actually take enough time to form the relationship, that's when the person on the street seems more open to listening to you, to believing what you have to say, and then to being more accepting of coming inside and trusting the process, if you will. So what then happened when I thought of that is, okay, that's very similar probably across a lot of spheres in supportive housing, but that takes time, and time costs money. And that goes right back to the, I can't imagine it working if you had to see somebody every 15 minutes. I mean, I know how frustrated I get when you walk in and you get 15 minutes and I don't have the types of barriers that you're talking about. So one of the things I was hoping you could talk a little bit more about is kind of the thing that comes up anytime we go in front of a funder and say we have this great program, you need to let us pilot it, which is what it sounds like you've been doing. We always get asked, is it replicable and is it sustainable? And so I just wondered what Van, you started by saying kind of like, tomorrow this funding's going to end. Yes. And, putting my selfish Common Ground hat on, that would be a disaster at our Common Ground sites. So I wonder if you could talk a bit more about the thinking about whether, number one, other organizations could do something similar, and what the plans are for kind of taking that soup and bringing it together.
Right. I think, unfortunately, part of the answer is we don't know, right? So Medicaid redesign is happening in New York State, like right now, as we all sit here, right? And so there's like $5 billion of DISRIP money, right? There's a lot of this care is going to be now funded through managed care organizations, including HCBS care, the home and community-based services care that was previously grant funded, right? My point being is that the way things are paid for, including medical care, but all this other stuff is changing right now, and it's certainly not clear to me how all this stuff gets funded a year from now, 2 years now, 3 years from now. And it's actually, I don't think it's totally clear to people up in Albany either, right? So that's sort of the bad news, right? Or that's part of the bad news. It's like, it's not totally clear, but I do think some of that alphabet soup, DISRIP money going through PPSs, the Coordinated Behavioral Care, IPA, which is going to be contracting with MCOs on behalf of agencies, including Common Ground and CCS. I do think between all of that alphabet soup, there's going to be ways to fund things like this. So that's the first thing, right? We've already alluded to the way managed care organizations and insurance funds medical care these days in this fee-for-service model, like leads to, this is why when you go to your doctor, you're sitting with your doctor for 15 minutes and then you're out of there, because your doctor's got to see 25 people just to keep the lights on, right? These people are not getting rich, by the way, right? So that's like clearly not going to work for us, right? I always say if you're going to do that, you might as well not do it at all, right? So we can never depend on all of our funding on that. However, there are these models out there being tested in various places that are more value-based and in a lot of cases also risk-taking on, right? So for example, you get a per head, per month kind of billing model where we give you a certain amount of money per head, and then, if you spend all that money taking care of that person, then you break even. If you don't spend all the money, then you pocket the difference, right? But then the risk part is, but if that person ends up in the hospital and it costs more than what we give you, right? So is there a way to do that kind of billing that makes more sense for this kind of thing? And then a more value-based thing would be something like, okay, we'll pay for however much it costs, and if you, so an insurance company would say, okay, we'll pay for however much it costs, but then if you beat a goal, right, then we'll share the savings, like that kind of thing. And then if you go over the goal, then no contract next year, like that's right. So there's these like billing models out there with managed care organizations that are floating around now that we might be able to apply to this. And then the last kind of hope that we have is, remember that I described to you how psychiatry for years already has been basically contract funded, right? So for example, a supportive housing site gets their contract from the Department of Homeless Services or HUD or Department of Health or some combination, and they decide to spend some of that contract on the psychiatrist, right? We're hoping that places will now decide to spend some of that funding on primary care on site, and that also hoping that some of those contracts get a little bit bigger as governments realize that it's actually very cost effective to put some money up front in supportive housing for this kind of thing. So that's all the things we're hoping some of that stuff goes through for us.
Just to add slightly to what Van was saying, or highlight cost effective, he just said. And if you look at the last two bullets, the reason why, at least in theory, with the right partners, this is feasible and replicable is because even though it's resource intensive as an investment, the returns are great. It is extremely resource conserving in the long term. And so it's not like we just need money for something good, which is part of it, obviously, but we can even make the case that it's actually going to save the system money. And given where things are at right now in history and the cost of healthcare in this country, if we can find people to see this vision and look at the data, then I think that it is something that can be sustainable. We just have to step outside of the boxes that we're used to in terms of healthcare funding.
I want to ask one more question and then open it up to the audience. So in thinking about kind of integrating primary care into supportive services, we think about how expansive it can be, and I know we went through kind of a list of a lot of different things that are covered via social services and medical services. I wonder if you could speak just for a few minutes about in our sites we have a large growing aging in place population, and so with CUCS, with Janian, we created and piloted a senior specific program called ECHO, Elder Care Health Outreach. And there is primary care and psychiatric care, and there is also integration with the housing staff, and all kind of towards the same goal, which is to make people healthier and more well. And I wonder if you could just give folks a couple seconds on that.
Absolutely. So we've had very good experiences with the ECHO program. I would say, just to start out with what the biggest challenge was that we found that a number of the seniors in our care were actually getting pretty decent care in the community. We think that it's because the seniors in our housing had been living in the community for some time before, and so they had relationships with providers in the community that Most of them have Medicare, and so accessing services in the community, when you have Medicare, which is a single payer essentially, it was just much easier to be able to access services in the community. And so we were trying to better understand how we can improve health outcomes when a good portion of the people that we thought we'd be providing more primary care services were actually doing well in the community. And the last thing that we want to do is to step people back in their sociooccupational dysfunction. We want this to be something for people who need it most and then to get them back into the community. And so what we started to develop was group visits that were open to people in addition to our ECHO tenants, but were largely ECHO tenants. And they would focus around wellness and healthcare maintenance as well as some illnesses. And I'll give you just 3 examples and then we can move on to other questions. There would be a diabetes group where people would come together. We would have a provider there. We would talk about different diabetes medications. What is diabetes? Asking people to check their sugars and helping people to learn how to interpret it. That would be an example. Another example was a group where we would do a falls prevention program. And so there are various protocols for fall preventions, and we would provide as a sort of gift, if you will, for attending the group, socks with non-slip surfaces on the bottom. We would talk about ways that you can decrease your falls, set up your apartment in those ways, and worked with the Common Ground staff to try to assist people who needed grab bars and shower chairs, all as part of this workshop to improve their health outcomes. And then finally, the one that's happening in another day or two is staying safe in the sun, so how to protect yourself in the sun, things of that nature. There are a number of them. Those are just a spattering of examples.
So questions from the audience? Sure.
Hi.
Thank you.
I work at the Andrews, and we're a safe haven. And I have a question. I don't know if this would be pie in the sky, but one of the things that happens is, and I'm sure you guys know clients this happening too as well, is they go to the ER, and as soon as they say they've been homeless, or the ER staff recognizes them from past, especially if they've been drunk or whatever, they don't get treated very well, so then they don't want to go back. At the same time, we have had incidences, like we had 2 last week where our on-site doctor, who's a psychiatrist, spoke to the hospitals. One was a medical, one was a psych. In both cases, the hospital didn't really want to hear anything she had to say. They wanted to just discharge back. We had a case where last week we were told this man had pancreatic cancer. He had 6 months to live. He was psychiatrically unstable, and they got permission to do operation against his will. Well, Tuesday they called us and they said, guess what? He doesn't have cancer. He's psychiatrically stable, and we want to send him over. Can we send him right over to you? So my question is, I know that like with a lot of us, if we are put in the hospital, our doctor follows us. Our doctor comes. Can we either have, is it possible to have something like to not only have an on-site primary, but somebody that would follow them in the hospital, or would we be able to partnership with doctors in the hospital so that, let's say, our client goes to, let's say, Bellevue, Dr. XYZ would be the one that would treat that client, and we would have that relationship so that it wouldn't be feeling like now we've got the doctor in the hospital against us, and maybe then the client feels like, they're not getting the care they need, that we're falling down on the job because we had somebody, he came back, we didn't think it was really safe for him to come back. We put things in place since he's come back, but he was a little nervous, so it wasn't like he was begging to stay to come out of the hospital. So I don't know if that's all pie in the sky, but is that a possibility to do anything like that?
Okay, so I'll start with the idea of like your personal physician, like actually participating in the care in the hospital. That actually happens a lot in like just sort of in the world. So for example, my primary care physician has admitting privileges at Beth Israel Hospital. So when his primary care patients are in the hospital, he can go visit them in the hospital, and he works with the team there, right? So that doesn't exist right now. As far as I know, there's no one doing that for homeless people or formerly homeless people in supportive housing. However, I'll tell you where the opportunity for that is. So in order to apply for some of this DSRIP money, you have to be a performing provider system, a PPS, and the PPSs are all run by the huge hospitals. Like, so for instance, Mount Sinai just got awarded $389 million over the last 5 years, right? They just got their first check for $13 million. So Sinai is like really, so now they've got 389 million reasons to try to figure out ways to do this better. And if I said to, and I'm sitting on their clinical committee, by the way, now, and if I said to them something like, what if I followed the patient in the hospital? Wouldn't that make things more efficient and effective? And I bet a couple of people over there would be like, And it's like they're sitting on all the money right now. And they have to include people like me in their PPS, right? That's the mandate from the state. So the list of agencies in the Sinai PPS is like, there's like 200 entities in it, including us two, right? And probably other people in the room. So I hadn't thought that through, but I think that's a possibility. Before that, and what's been going on already for years is that individual physicians and primary care providers at housing sites, like the Andrews, for example, like if you had a primary care provider at the Andrews, my recommendation to that person is like start getting to know the people at Bellevue, so that when you're on the phone with the inpatient doctor at Bellevue, it's like somebody you already know. Like I trained at Bellevue, so often when I call Bellevue, the person on the other side of the line is somebody I trained with, somebody I know, so that makes it go much smoother. But if you don't have that previous relationship, it just takes relationship building, and that comes with time. However, the clinician often like gets a better even initial conversation on the phone than the social worker. Unfortunately, you know that's the case, right? So.
And just to add to that, I would say that I also now have privileges at 2 of the hospital systems in the city, and so there's also a lot of opportunity there to grow that. And whether it's if I'm actually rounding on the tenant or whether we have developed relationships through hospitalists, which is another way to handle it, that's one thing to think about. I will say that part of the role of the PCP on site, which may or may not be different than the provider at the Andrews right now, which is that there's time in the schedule, in addition to the 1 hour of case conferencing that's specifically for the tenants who are seeing that provider that day, is to do administrative and care coordination. And so our providers actually have time to get people on the phone at the various hospitals where they're hospitalized. And we have really dedicated providers, and they are in the process of actually developing relationships with the providers in the hospitals, because when somebody's admitted and, oh yeah, we spoke a few weeks ago. And so that is happening on the ground on some level already. And I think that our patience time is one of the reasons that we're able to do that.
Other questions, comments?
You brought up the question, by the way, I love the Andrews and used to work there. But in terms of time, how do you see electronic records sort of reducing the amount of time and increasing the communication and effectiveness of what you're doing?
Go ahead, Eve
Yeah.
wants to take this one.
Oh, electronic records. So we use electronic records, and the primary care providers and the psychiatrists in Janian service use electronic health records, and those are used in communicating with the housing and social service staff and vice versa, as well as in-person verbal communication. And it's something that saves a lot of time, but takes a certain amount of time. And I think that the electronic medical system that we use, which is eClinicalWorks for the primary care, is a really great and flexible tool. And it's the same one that's used by other medical systems in New York City as well, which is also helpful. And having meaningful use of that system is something that means both being able to bill at a meaningful use rates according to the ACA, but also is something that allows more effective communication among providers, housing workers, and social service workers. So I don't know if that got at what you meant, or if Margo, you have more.
This is not exactly what you asked, but there is a significant dark side to electronic medical records, which is, right.
Yes.
There's
I
probably,
was giving the rosier picture.
Right.
Yes.
so I guess, right. I'm going to just say one of the dark things about it is that So one of the great things about eClinical Works, it's like really designed to bill out of, right? But the problem with that is then you could bill out of it, right? And in order to create a clean bill, your clinician's got to document, X, Y, Z, ABC things. Often a bunch of things that I wouldn't normally care to document about in my routine bit, right? So I'm having to spend time massaging my chart that I could be spending doing other more enjoyable things, right? So that's that's the sort of the dark side of the electronic medical record thing.
No, they're wonderful. Don't listen to him.
So why don't I take us from the low side to the high side too, which is that they almost across the board, they tend to be cumbersome. They tend not to be designed by clinicians. They tend to be designed by IT people and corporations. And so there is a lot of upfront cumbersomeness to their functionality. That having been said, if we have an outreach team provider, a psychiatrist, for example, who sees somebody for their evaluation in the field, and that person then goes to the Andrews and stays at the Andrews and then ends up finding housing at the Lee, all of those psychiatric evaluations, every time they saw a PPOH Janian provider, they're going to have access to when that person gets to the Lee and where they're going to start seeing their new primary care provider at the Lee potentially. Same thing there's a lot of movement when you're in this transitional phase, and so that helps a lot. When we have integrated care on site with our mental health providers and our mental health providers and our primary care providers, we see and know and can read each other's notes about what's going on with those people, and that's really important. I will say, however, that they are, or at least will be, or have the potential to be, a treasure trove of demonstrating our worth. So we're going to be able to use the medical record once we, get down with all the functionalities to show how much improvement we are making in terms of some of the medical outcomes. And so it hopefully will be able to help us to prove our worth in ways in addition to the other outcomes research that we do at the organization.
Also, though, another benefit is that it's a piece that's potentially collaborative with the service recipient, because it allows a greater degree of transparency to the person receiving services to examine their own medical records, to see things changing over time, and that collaboration is an essential part of integrated primary care as well.
Yeah, it brings a rehabilitative piece.
Yes.
Yeah, we're working towards develop visit summaries that whenever somebody leaves a visit, they go and they know what their medications are, if there are any changes, when their lab work on all the referrals they're going to. And actually, we have someone that we brought on to work on a project over the summer at Janian who's going to be starting to develop the patient portal, which is going to enable the tenants to have more direct access to their providers and to their medical information in a more empowerment model where they're able to access the on-site computer labs at our buildings.
And a patient portal is one of the requirements of a patient-centered medical home, which I'm not totally understanding this, but I think you have to be a PCMH in order to bill in certain ways. So patient portals are going to be much more common in the next couple of
So
years.
you could do kind of, or almost a concurrent documentation.
Oh, we're already doing, with the patient, yeah. Ultimately, I think we'd like to do that. Right, the more, an educated consumer is your best customer, right? Like the more your patient's involved, what we found is the better it all goes. So yeah, we're looking forward to making that work.
Other questions, comments?
All right, thanks a lot, everyone. Thanks.